CNA Dosage Calculations. Welcome to the quiz. Question 1. In the proximal convoluted tubule PCT, the majority of filtered bicarbonate is reabsorbed. How is this accomplished, given that HCO is not easily transported across the apical membrane? Option A. It is co-transported with sodium via the NBSU1, a symporter. Option B. It diffuses passively through paracellular pathways. Option C. It is indirectly reabsorbed via the secretion of H ions, which combine with filtered HCO to form CO and water in the lumen. Option D. It is exchanged for chloride ions via an antiporter. The answer is C. Bicarbonate HCO is a key blood buffer. The PCT reabsorbs about 80 to 90 of the filtered HCO, but it does so through an ingenious indirect mechanism because the apical membrane is not very permeable to HCO. The process involves H secretion. PCT cells secrete hydrogen ions H into the tubular lumen via Na/H exchangers N-Chi3 on the apical membrane. In the lumen, the secreted H combines with filtered HCO to form carbonic acid HCO. Carbonic anhydrase type 4, which is bound to the apical membrane of PCT cells, rapidly catalyzes the conversion of HCO to carbon dioxide CO and water HO. CO is highly lipid-soluble and diffuses freely back into the PCT cell. Inside the cell, carbonic anhydrase type 2 catalyzes the reverse reaction, combining CO with OH from water to reform HCO. This new HCO is then transported across the basolateral membrane into the blood, usually via a Na-HCO cotransporter NBSU1. Thus, for every H secreted, one HCO is effectively reabsorbed. Option A describes the basolateral exit step, not the apical uptake. Option B is incorrect for HCO. Option D describes a Cl/HCO exchanger, which is involved in other processes like red blood cell anion exchange or gastric acid secretion. Question 2. The concept of free water clearance is used to assess renal diluting capacity. A negative free water clearance indicates the kidney is Option A. Excreting dilute urine, as in diabetes insipidus. Option B. Unable to concentrate or dilute urine, as in renal failure. Option C. Reabsorbing pure water concentrating urine, as in dehydration or SADH. Option D. Responding appropriately to a water load. The answer is C. Free water clearance, CH2O, is a theoretical calculation that represents the volume of solute free water being either excreted or reabsorbed by the kidneys. It's calculated as CH2OV urine flow rate COSM osmolar clearance. One positive CH2O means the kidneys are excreting more water than solutes, producing dilute urine hypotonic. This is the appropriate response to a water load. 2 CH2O0 means the kidneys are producing urine isotonic to plasma, e.g., in renal failure when concentrating/diluting ability is lost. 3 negative CH2O means the kidneys are reabsorbing more water than solutes, producing concentrated urine hypertonic. The body is actively conserving pure water. This occurs in states of water conservation, such as dehydration, SIAD, or the action of ADH. Option A describes a positive CH2O. Option B describes CH2O near zero. Option D would also yield a positive CH2O. Question 3. Hyperkalemia elevated serum potassium is a medical emergency due to its effect on cardiac muscle. What is the characteristic early ECG change associated with hyperkalemia? Option A. Prominent U waves and a prolonged QT interval. Option B. Tall, peaked T waves. Option C. Flattened T waves and ST segment depression. Option D. Shortened PR interval and widened QRS complexes occurs later. The answer is B. Potassium is critical for the resting membrane potential of cells, especially excitable cells like cardiac myocytes. Hyperkalemia high serum K makes the resting membrane potential less negative, depolarizes it. This affects the cardiac action potential, particularly the repolarization phase. The earliest and most characteristic ECG change is tall, peaked or tented T waves. This occurs because the rapid repolarization phase 3, is accelerated. These peaked T waves are usually seen when serum K is above 55 to 60 milliequivalents/L. As hyperkalemia worsens, further changes occur. P waves flatten and disappear, the PR interval prolongs, the QRS complex widens due to slowed conduction, and eventually it can degenerate into a sine wave pattern. Ventricular fibrillation or asystole. Option A, prominent U waves. Long QT is classic for hypokalemia low-K. Option C, flat T waves. ST depression can be seen in ischemia or hypokalemia. Option D, shortened PR. Wide QRS are later, more severe signs of hyperkalemia, not the earliest. Question 4. Metabolic alkalosis is often associated with volume contraction, e.g., from vomiting. Why is this alkalosis termed chloride responsive, and how does it correct with saline administration? Option A. Saline provides bicarbonate to buffer excess acid. Option B. The alkalosis is maintained by chloride depletion and hyperaldosteronism. Saline provides volume and chloride, allowing the kidney to excrete bicarbonate. Option C. Saline directly stimulates respiratory centers to retain CO. Option D. Sodium in saline competes with hydrogen ions for secretion in the collecting duct. The answer is B. Chloride-responsive or saline-responsive metabolic alkalosis commonly occurs with volume loss, e.g., vomiting, diuretic use. The sequence is 1 loss of gastric acid HCl from vomiting directly removes H and Cl, leading to alkalosis and chloride depletion. 2 volume loss activates the renin-angiotensin-aldosterone system, RAS. Aldosterone promotes Na reabsorption and H/K secretion in the collecting duct, worsening the alkalosis. 3. The kidney tries to excrete the excess bicarbonate HCO, but to do so, it needs an anion to accompany sodium in the urine. With severe chloride depletion, there isn't enough Cl available. The kidney then reabsorbs Na with HCO to maintain volume, perpetuating the alkalosis. Administering normal saline and ACL corrects the problem by A. Restoring volume, which turns off the RAS. B. Providing abundant chloride, which allows the kidney to excrete Na with Cl instead of HCO, and also enhances HCO excretion. This allows the kidney to correct the alkalosis. Option A is incorrect. Saline does not provide HCO. Options C and D do not describe the primary correction mechanism. Question 5. Which segment of the nephron is the primary site for the regulation of calcium reabsorption under the influence of parathyroid hormone PTH? Option A. Proximal convoluted tubule PCT. Option B. Distal convoluted tubule DCT. Option C. Thin descending limb of the loop of Henle. Option D. Collecting duct. The answer is B. Calcium Ca reabsorption occurs along the nephron, but its fine regulation is hormonally controlled. About 70 is reabsorbed passively in the PCT paracellularly, following sodium and water. Another 20 is reabsorbed in the thick ascending limb TL via paracellular transport driven by the positive lumen voltage. However, the primary site of regulated reabsorption is the distal convoluted tubule DCT. Here, about 10 of filtered Ca is reabsorbed, but this portion is crucial for determining final urinary calcium excretion. Parathyroid hormone PTH, released in response to low blood calcium, acts directly on DCT cells. It increases the activity of apical calcium channels TRPV5 and basolateral calcium pumps/exchangers PMCA and CX, stimulating active transcellular calcium reabsorption. This increases blood calcium levels. Option A, PCT reabsorbs the majority, but is not the primary regulated site. PTH has minimal direct effect there. Option C is involved in water reabsorption, not regulated calcium transport. Option D is not a major site for calcium reabsorption. Question 6. A patient presents with polyuria, polydipsia, and hypernatremia. A water deprivation test fails to concentrate the urine, but exogenous ADH administration does concentrate it. This indicates Option A, central diabetes insipidus deficiency of ADH production. Option B, nephrogenic diabetes insipidus renal resistance to ADH. Option C, primary polydipsia psychogenic water drinking. Option D, uncontrolled diabetes mellitus. The answer is A. This scenario describes a stepwise diagnostic approach for diabetes insipidus DI, which causes the inability to concentrate urine. 1 water deprivation test. The patient is deprived of water to stimulate maximal endogenous ADH release. If the kidneys can respond to ADH, urine should become concentrated high osmolality. Failure to concentrate indicates either a lack of ADH or kidney resistance to it. 2 exogenous ADH administration, synthetic ADH desmopressin, is given. If the kidneys now concentrate the urine, it proves they are capable of responding to ADH. Therefore, the problem must have been a lack of endogenous ADH. This is diagnostic for central neurogenic diabetes insipidus, where the hypothalamus or pituitary fails to produce/secrete adequate ADH. Option B, nephrogenic DI, would show no concentration even after exogenous ADH because the kidneys are resistant. Option C, primary polydipsia, would show normal concentration after water deprivation because ADH is present and kidneys work. Option D, diabetes mellitus, causes polyuria from osmotic diuresis due to glucosuria, but urine can be concentrated for other solutes, and it doesn't cause hypernatremia, typically causes hyponatremia or normonatremia. Great job! Don't forget to subscribe. Bye!